We would now like to introduce our first speaker, Dr. Gabrielle Bonham from the University of Pittsburgh.
I'd like to thank the organizers and the panel for the opportunity to speak this morning. My talk is on a patient who presented saying, "I'm on so many medications and now I can't see." I have no financial disclosures. So our story begins with an unfortunate 54-year-old man who presented with bilateral vision loss that occurred simultaneously. He'd been noticing progressive worsening over the past 2 months, with accompanying symptoms including a biparietal headache, bilateral retrobulbar pressure, a fullness in his ears that he described as muffling of his hearing, as well as imbalance and dizziness that seemed to be triggered by head movements. Past medical history was significant for hypertension, ventricular tachycardia, fibrillation, and PVCs. He was recently admitted for catheterization, ablation, and cardioversion after a cardiac event. He is unfortunately not treating his obstructive sleep apnea and has long-standing migraines. Surgical history reflects his cardiopathy. He's had a dual-chamber defibrillator placement and very recently insertion of a new right atrial lead. Family history reveals relatives with glaucoma, hypertension, and heart disease. His medications reflect his medical issues: amlodipine, amiodarone, atorvastatin, losartan, doxazosine, sildenafil, and metoprolol. He has no known allergies. So on initial presentation, he did present with decreased acuity in both eyes, down to 20/60 in the right eye and counting fingers at 1 foot in the left, with a left afferent pupillary defect that was fairly significant. Color vision reflected a dyschromatopsia that was pretty severe in each eye. And while IOP and motility were normal, he did have sectoral disc edema in each eye with pallor of the left disc and accompanying flame hemorrhages. So we did obtain visual testing given these findings. And if you look at slide left, you can see the right field shows pretty dense central loss, and the left does as well. As he was unable to perceive the stimuli, the size 3 on the Humphrey, we decided to go to manual perimetry for the left eye, and you get an idea of a central loss as well as a dense altitudinal loss. Looking at the OCT, we see that the nerve fiber layer is supernormal in both eyes, and this really does correspond with the global edema in the right nerve and the sectoral edema of the left nerve. So at this point, I think it's a good time to sit back, and with the information presented, I'd like to ask the audience, what is the most likely diagnosis? What's your leading diagnosis for this patient? Is this A, a compressive lesion, a tumor? Is it B, increased cerebrospinal fluid pressure, papilledema? C, is it GCA? Always have to be worried about that. Is it a toxic optic neuropathy or NAION? And please respond. So we see a pretty broad spectrum, pretty wide spectrum of answers. And so I think it's probably a good time to let our panel weigh in and see if they can dissect this case further.
So panel, do you agree with the audience here?
Sort of. The vast majority of you picked out, I think, what the 2 most likely diagnoses would be in this setting. This patient has a lot of vascular disease, so NAION is certainly a possibility, but the patient's also on a couple of drugs that could cause a bilateral process that is, in this case, an anterior optic neuropathy.
Yeah, I'd make the point that compression wouldn't be a good guess here with, papilledema wouldn't be a good guess here because of the presence of a pretty advanced vision loss at the time, unless, of course, it was a Foster-Kennedy-like, which was probably the distractor part of this. And looking at those 2 discs, I think one may have happened before the other, not by months or years, but maybe by days or weeks. And, that may make more room for what we think is not a bilateral disease, particularly non-arteritic anterior ischemic optic neuropathy, but more sequential disease. And in the setting of the pharmacologic risk factors, it would seem like D&E are the most likely at this point.
So do you want to know when he took his last sildenafil?
As much as anything.
Yeah, it was about a month ago, so it was within the time course of his vision loss.
Yeah, I mean, this is just, Nick just mentioned to me, this couldn't be a real case. It's too hard. This patient has, a history of hypertension, is on 2 medications, as Neil pointed out, that could cause a toxic / NAION picture. He's also got obstructive sleep apnea, which hasn't been attended to yet, so that's a risk factor. And then you always have to keep in mind the possibility of GCA, as we heard in the previous section of this symposium, in any patient who presents with a typical picture of bilateral sudden visual loss with swollen optic nerve. So it is a tough case. I think I'll leave now.
Well, I think you have to decide in this setting what are treatable causes of this problem, either in preventing further visual loss or possibly even in improving what loss of vision has occurred.
The other factor that might be playing a role is presumably his high cholesterol. It's not specifically mentioned, but he's on atorvastatin. And I think dissecting out the patient's history, it sounds like he really is describing a progressive vision loss rather than sudden vision loss. The first eye to go can sometimes be difficult to know a lot of detail about it, but when the patient's describing that the vision is getting worse and worse and worse, that would be unusual but not exclusive to anterior ischemic optic neuropathy.
Certainly, in terms of the erectile dysfunction drugs, we would expect something acute and immediate after taking the drug. So that would be much less likely than amiodarone, which, of course, is one of the issues. Whether it's toxic or an ischemic process is another story entirely.
And the other thing that argues for toxicity is his vestibular and symptoms.
Right.
And what kind of workup would the panel like?
Could I just make just one other point apropos what Judith said, but just don't forget in patients with NAION, a significant percentage of them do have a progressive course over the first 4 to 6 or 8 weeks. So just remember that too. They don't all have this apoplectic acute drop in vision and then stabilize or get a little bit better. Some of them have this more staircase or stuttering course.
Which might be relevant a little bit later today.
Quick question from the audience. Isn't the patient too young for GCA? 54-year-old?
We always have these issues of what's your youngest patient as opposed to what's your youngest patient. It is a bit young, but it's close, and you just have to at least consider it, if only to dismiss it and move on to something else.
Yeah, I would think that you're obviously going to do a SED rate and a C-reactive protein as part of the check the boxes. I don't think I would do an MRI scan looking at those discs because they don't look to me like papilledema and they look so much like ischemic optic neuropathy. I would struggle between whether either of the entities we're alluding to exists, namely an amiodarone-related bilateral NION or near sequential NION, and I agree that he's too distant from his sildenafil exposure for it to be relevant at this moment.
The only workup I would do would be to contact his cardiologist and find out if he absolutely needs the amiodarone or if there's another drug that would help him.
Yeah, just to amplify what Neil said, I don't think I've ever had a cardiologist who isn't willing to stop the amiodarone. If you phone that cardiologist and say, listen, I think Mrs. Jones is losing vision because of that medication. So almost always they will do something else and get the patient off the amiodarone.
So no one on the panel would get neuroimaging?
Well, you can't probably do an MRI because of the pacemaker, but I might want some vascular imaging.
Well, you know you're going to, at the very least, you're probably going to see some vascular changes given all of his vascular risk factors. I'm not sure it would help me. I know the previous session, we're neuro-ophthalmologists, so we get MRIs, but sometimes you just have to resist that impulse.
So you've decided it's not a Foster Kennedy with an unilateral optic neuropathy and papilledema?
Well, he's got visual loss in both eyes,
That's
so
what,
it
that
would
nerve is
be-
being compressed
Yeah.
by the meningioma.
The problem is that you have an anterior optic neuropathy, and that would be extremely unusual in a Foster Kennedy, or I think this is at most a pseudo Foster Kennedy.
The audience wants to know, could this be MOG? Could this be an atypical optic neuritis? Would we miss it if we didn't get imaging?
Well, anything's possible. I wouldn't have thought so because of the progression. The progression isn't right. It's too slow for MOG, I would think.
So I agree with the panel, basically. We had so many things to rule out, and a lot of the testing that we did was, in fact, just to rule them out, as Dr. Volpe had mentioned. So in the office, as with all neuro-ophthalmology patients, we did check the blood pressure. Of course, he had malignant hypertension in spite of his 3-drug therapy. Sed rate and CRP were normal. We checked for a few inflammatory and infectious causes of optic neuropathy. They were all negative. We did obtain neuroimaging for several reasons. One, he was giving us headaches. You know, then it's kind of hard with bilateral swollen nerves and headaches to completely rule out an intracranial pressure issue. And I agree with Dr. Warner that looking at the vasculature was quite important because a bilateral ischemic process could present with carotid stenosis. CT head, CTA head and neck with contrast did not show any of these disorders. CTV was done at the same time as the CTA, and there was no sign of sinus thrombosis that could otherwise cause increased intracranial pressure. And lumbar puncture was done because the headaches were progressively worsening and the opening pressure was normal.
I have to say that I don't really think that this type of disc swelling, even if you think it's post-papilledema, it really doesn't look like that at all.
I agree. It looks ischemic, but I've seen some cases of sleep apnea-related bilateral disc edema that look very pale, very much like an NAION sectoral swelling, and lo and behold, the ICP is 30. So I think given the headaches, given the dizziness, he had some other neurological symptoms that I couldn't really explain from his medical history, that I thought it was reasonable to rule that out.
I don't think I would have done a lumbar puncture, but I would have done everything else.
I think this qualifies as extensive testing,
That's
doesn't it?
extensive. Yeah, that's extensive.
I think also we get used to being able to look at the optic nerves on an MRI scan and reassure ourselves that it really does look ischemic as opposed to infiltrative or inflammatory. And we don't have that luxury here. And so there are going to be a few more check boxes that you end up feeling a little uncomfortable about. So doing an LP to look for inflammatory, infectious, and infiltrative issues is not completely unreasonable, I think, guys.
Particularly since this morning we've already heard about atypical optic neuritis presenting in older patients with odd-looking discs. We did send an NMO, IgG, and a MOG, and of course the CSF analysis helped rule those out as well. So on our differential that the panel has already covered, we've considered an AION related either to the obstructive sleep apnea that he wasn't treating or the hypertension. Amiodarone toxicity, certainly we should consider. And so right then, I stopped, called the cardiologist. He was in the office, opened up the chart, and at that moment told me, tell him to stop taking the amiodarone. And this has been usually the rule whenever we call over. So don't hesitate to do so. GCA, I agree. Patient was too young, review systems didn't fit, and sed rate and CRP were repeated again and did not elevate. So I thought that that's of low clinical suspicion at this point. And Dr. Miller's point about the sildenafil not fitting temporally with the presentation of vision loss is well taken. We did ask the patient to stop taking the sildenafil, though. So we monitored the patient expectantly, and at his 8-week follow-up, he presented with a significant improvement in his acuity from 20/60 upon initial presentation to 20/25 in the right eye, and improved to 2200 from counting fingers at 1 foot in the left eye. So fairly significant improvement in his central scotomata as well, seen both on the Humphrey in the right eye and the Goldman in the left. You can see that the disc edema that was previously noted has now been replaced with bilateral disc pallor. And this is consistent with our OCT findings. His nerve fiber layer and ganglion cell are now both thin. So in summary, this case illustrates sometimes the complexity, the complex patient that we often run into in neuro-ophthalmology, but you really should consider amiodarone-associated optic neuropathy, particularly when the vision loss is reported as bilateral, simultaneous, not sequential, and progressive or insidious in a patient who's taking that medication. A broad differential can come up, and many times you're parsing hairs as to what tests to obtain, but compressive lesion and increased intracranial pressure have to be considered at least, and GCA is always in the differential when the patient's over 50. One way to rule out NAION is to look for a sequential pseudo-Foster Kennedy-like presentation rather than a bilateral, simultaneous, and insidious vision loss as our patient presented with. And finally, one of the most important things that you can do as an ophthalmologist for these patients is to contact the cardiologist directly. Call them the same day. Many times they're very receptive, and as the panel mentioned, it's extremely rare. I can't think of a case where the cardiologist really said that it was medically necessary for the patient to continue on the amiodarone. Invariably, they will switch to another medication or even stop it. I've had a cardiologist say, I didn't know they were still taking this med. So it's usually not an issue. And because over 50% of patients with amiodarone-associated optic neuropathy, upon cessation of the amiodarone, their vision can improve. And so you'd really want to make sure not to miss that opportunity.
Thank you.
I don't think this guy's vision's going to get better. But maybe the less affected eye will be a little better. It really, what it begs the question is, what's the panel's position on a unilateral, seemingly straightforward NION who happens to be taking amiodarone? Is that a reason to discontinue it if, for instance, it is being used for a life-threatening ventricular arrhythmia, or is there a gray area there still?
I think for sake of time, we'll just move on to the next case.
Yep.
Thank you very much.
Down, boy.
It's out there.